What's up, everybody? Welcome back to this episode of Show and Tell, where we talk about all things art, all things music, and all things Boston. My name is Cricket Smith, and this episode we will be discussing women's health. As you can see, I have a different co-host here with me today. Co-host, can you please introduce yourself?
What's up, Boston? I am Shakira Robinson. As you know, I am a community engagement specialist with the Massachusetts Community Engagement Alliance. We are housed at BMC, Boston Medical Center. Thank you for having us.
Thank you for being here. And we have two beautiful ladies here with the Boston Medical team. Can you ladies introduce yourself and include your specialty?
Absolutely. Thank you so much. This is a great opportunity for us to be in community here in Boston. My name is Noel from the Department of Obstetrics and Gynecology at Boston Medical Center, where I specialize in gynecologic care, focusing on fibroids, endometriosis, PCOS, benign non-cancerous GYN conditions, and minimally invasive gynecologic surgery. So, yeah.
Nice.
Ooh, she ate that up, didn't she? She ate it up.
You asked what I did.
That's good.
That was beautiful.
Yes. My name is Naomi Ko, and I'm a physician, and I specialize in breast cancer. So all things breast cancer is kind of what I'm all about, and I'm really, really happy to be here.
Absolutely.
Thank you for being here.
Yeah.
So let's start with the obvious question. What is PCOS?
What is PCOS? PCOS stands for polycystic ovarian syndrome. And that is a syndrome that involves, as it says, multiple small, tiny little cysts on the ovaries that are seen on ultrasound, and then a constellation of symptoms and signs that are related to elevated androgens, which are basically a type of hormone. So examples would be testosterone and DHEAS, which is another type of androgen, or we consider them male hormones, but they're really not male hormones. They are hormones that are in males and females. And so when you have an excess of those hormones, you end up having PCOS. So you see certain things on the ultrasounds. You see signs of elevated testosterone, both on people's bodies clinically, and then also sometimes you can check lab values. And then it also affects how you have your periods. So many people with PCOS don't have regular periods. So they'll go months without having a period, which we call oligomenorrhea. You're not having a lot of periods.
Oligomenorrhea.
Wow. To piggyback off of what you just said, Dr. Noel, for individuals who are watching who might think they may have PCOS or are on the cusp of whether or not they should ask their doctors about whether or not they have PCOS, what are some symptoms or signs that, the common person might have that they could be aware of or they might want to mention to their doctors?
So one of the first things that people become aware of is irregular periods. So they're missing their periods. They're not necessarily at risk for pregnancy to stop their periods, and they're so that's one big sign, and that's one big reason why people see their doctor to figure out what's wrong with my periods. Another one would be if they have signs of that elevated testosterone, and so some people present. The testosterone does affect how you have your periods, and I can go into that more. But some people report like abnormal hair growth, so they find like on their kind of like midline or male pattern hair loss on the head, or like kind of mustache, chin hairs, chest hair, like, and that can be difficult because sometimes people do so many things to remove hair these days, and it's just kind of what people do. But it's kind of like something that seems a little bit abnormal. So you kind of have to ask questions to kind of tease out what people's practices are too, to kind of manage that. Acne can also be something that people have. And then weight management issues can also be of concern.
Does estrogen play a role in PCOS too, or is it mostly the androgen?
Well, mostly it's considered a condition of high androgens.
Okay.
However, with that, there's also an imbalance in the other kind of hormones that you're talking about, estrogen and progesterone. So many people with PCOS have what we call like just hyperestrogen, and that can be seen in people with PCOS, mostly because it is a metabolic condition. Sometimes there can be elevated weight and elevated BMI, particularly in the central area, and actually fat cells can produce hormones and lead to elevated estrogen levels. So many people with PCOS also have an imbalance of estrogen.
We're learning a lot
I
already.
know, right? Like, what do I ask next? Dr. Ko, from your perspective, is there a direct relation, or could there be a direct relation between PCOS and breast cancer?
Yeah, so I was just thinking about how interesting that was
Yeah.
and how much hormones play a role in women's lives.
Yeah.
And for breast cancer, because fat cells are called like adipose tissue, we also call are also apocrine glands, which are glands that secrete hormones. And that hormone in fat cells is estrogen, as we just heard about PCOS. So when you have an excess of estrogen, you have a higher risk for breast cancer. And that's also the link of obesity and breast cancer is a very strong link. And we think of it as, well, when you're obese and you have more fat cells, you have more estrogen. And more estrogen exposure means more higher risk for breast cancer. I'm going to take it to the next level.
Okay.
I'm taking it next level.
Okay, let's go.
Okay, and so more estrogen. So when we think about risk factors for breast cancer, a lot of things people need to know is the more exposure you have to estrogen, the higher your risk of breast cancer. It looks like this. If you get your period really early, if you don't get menopause until pretty late, if you take estrogen supplementations, if you don't have any children because you never go into pregnancy and you're always having a lot of estrogen because you're always menstruating. So women who do not have any pregnancies or children have higher lifetime estrogen, higher risk breast cancer.
Wow.
So I just think of that link is definitely there.
Wow.
Yeah.
That link, I love that you elaborated on what I started, because if we're going to talk about cancer and gynecologic cancer, there's also an increased risk of gynecologic cancer with exposure to estrogen, specifically endometrial cancer. So endometrial cancer is one of the risk factors for that is obesity, high blood pressure, exposure to increased estrogen. So those are some of the risk factors for endometrial cancer. Endometrial cancer can also cause irregular abnormal bleeding, particularly if you're having bleeding after menopause. That's just not okay, and that can be a red flag for endometrial cancer and a reason to get evaluated by a doctor. A lot of conditions, both cancers and non-cancerous conditions like fibroids, for example, can be responsive to the hormones, either this elevated estrogen that we're talking about that can be within our body, but also environmental estrogens as well.
Wow. I have a question. More so, want to make a statement. We know from members of the community and on a previous episode that we had, there are people who believe in a holistic approach to medicine. And so as you were talking about extra levels of estrogen and how that could be dangerous, it made me think about the people who would try all these different substances that they found on Amazon. They heard about it on TikTok. And so I think what the audience should take away from this is that know what you're taking, right? Especially if you are at risk, if there's a family history of breast cancer or, endometriosis, we need to make sure that we're not putting ourselves at higher risk for these potential diseases because of these extra substances that we're taking that are not prescribed by a doctor, because a lot of people aren't aware that these substances are not always FDA approved. And so we're putting ourselves at a high risk for God knows what. So I wanted to make sure that we said that out loud in real time for the people who are thinking about, well, I take these substances because, and I'm fine. And they may think that way, but how often are you seeing your physician to know for sure you are fine? So I love that you talk about these opportunities for things to look for screening, and being able to report out to your doctors. So thank you for that.
What are some things that young women could do now to help maybe reduce their chances of either fibroids, endometriosis. And Dr. Coe, if you could follow up maybe to even reduce their chances of breast cancer at an early age. Because they say like mammograms start at like 50, but I sometimes feel like that's like a little too late.
It's actually 40.
It's 40?
It's actually 40. Really big deal. Yeah, I think it's a really important public service announcement for me to say right here, right now to the community. It's 40 years old. Is now the new standard for mammography, not 50, and especially in women of color. The reason they changed the age recommendation is largely for women of color, because we know women of color are getting diagnosed and dying more of breast cancer, and we need to be screening them earlier. And I mean, an ounce of prevention is worth like a ton of gold. So the more that you are in touch with your body, you are, aware of your breasts, aware of your breast health. You feel something, you see someone. If you feel something, do not worry alone. Get out and go see your primary care provider. Just ask. There's no question that's too simple. There's no question that's too dumb. There's no question that's don't a lot of women I've taken care of been like, I thought it was nothing. I thought it was nothing. And it's like, if you even worry a little bit, please come. Let us figure out if it's nothing.
That part.
Because you don't want to regret that, And it's the sooner you come in to care, the sooner we catch things, the earlier stage you come in with any cancer, the more curable it is. The longer you wait, and the more we give cancer a chance to grow, a chance to spread, then you need more aggressive therapy. So, man, I'm saying, like, come early, come often.
Oh, come early,
And
come often.
I have to say, like, and out of total respect for the community, I think we make it hard for women to come often and come early because we don't do a great job of earning trust. And I would like to say, for us, I know we both believe this, that we're here because we want to earn your trust. We want to be on this podcast. We want to be on this showing people we care. And if you trust us with your health and your most vulnerable things you're afraid of, we should show up for you.
Listen here. I'm like, she don't even know we cry,
I'm
baby.
dead serious.
I'm looking at Cricket like, we don't stop.
I literally, not
like
seriously.
it's not on the patients. It's not on the patients to be like, I'm so sick of hearing, you know what? Why didn't you go sooner? It's like, no. Why didn't we show that we're available sooner? It's not about putting the spotlight on the patients. It's about putting the spotlight on the providers. The onus is on us to earn your trust. And I believe that. Like, if you want to come and say, I'm taking this over-the-counter supplement because I believe in holistic medicine, amen. Talk to me, girl. Show it to me. I want to read the label.
No, seriously.
I want to look it up with you because I don't know if it's safe. I want to know if it's safe.
I write it down. I write it down. I take notes.
Hey, awesome. Give it to me. That's what it looks like. That's what it's about. It's about tell us what you're doing so we can help you. Not so we can shame you or make you feel bad or they're like doctors and we're like prescriptions, blah, blah, blah. We're like, no. It's like, bring me what you're doing so we can work together and talk about it.
Dr. Coe, you're making me think about, there are some community spaces, and shout out to Senator Miranda. She is very big on this with child maternal health. Where there's these baby showers for moms who are expecting, who may have, maybe some of them have health conditions or they don't. But now I'm thinking about, we need to be looking at women who we know are turning 40, and we need to be planning these parties, these showers.
I'm coming.
That sounds fun.
Invite me.
I'll be there.
You better invite me.
I've had a couple. I'm over 40.
A mammogram party.
Mammogram party.
Because so
great
many
title.
women
We can
are
find something
afraid to
cute.
turn 40 for other reasons.
Yeah.
But
Good for you.
embracing turning
Yeah.
40 with recognizing I'm taking ownership of my health.
Yeah.
I have a team of people behind me.
Totally.
There's nothing like community. And so being in community with other women in your age group who have the same fear or concerns, I
Love
think
it.
does something. So we need to talk about these mammogram
do it.
parties. Let's do it.
Let's do it. I have
Beautiful
a
idea.
patient advisory group as part of my lab, and we do a lot of research in breast cancer that I'm really dedicated to. And we formed a patient advisory group, and I mean, these women, they are motivated to get to those parties and like say, I had breast cancer, I survived it. All the women are black in my group, and they would love that, an opportunity to encourage and just say to people, go early. It's important.
Yeah.
It's not scary. Don't wait. That kind of stuff. Yeah.
Wow.
Yeah. Yeah.
Where do we go with this?
Back to Dr. Noel. Are there any preventative measures for the PCOS and endometriosis?
Oh, you asked me another question that I wanted to talk about.
I did.
Something
I got
about.
bad memory.
What was the question that you responded to? That I
Yes.
wanted to respond to.
Is there any way to like alleviate or
recognize-
like is there a way to recognize early signs
that's it.
of the PCOS or the endometriosis?
And the fibroids, yeah.
And the fibroids.
So one thing that I think is very common in our communities is that we're not talking enough about what a normal period is and what an abnormal period is, right?
Oh, yeah.
So
Yes, ma'am.
so fibroids are non-cancerous growths of the uterus.
I had one.
Yep.
So
She had one. And they can cause really heavy periods, right? Because depending on where they are and how big they are, they can cause like increased bleeding with a period, pain sometimes as well. And if they're really big, they can press on things nearby in the pelvis. So that's one thing. Endometriosis is a condition where the normal cells that are supposed to be in the uterus, in the womb, and shedding with the period, those cells are found somewhere else.
Ooh.
So
Like where?
like on the ovary.
Oh.
Or back behind the uterus, or on the surface of the bladder, and there's some other rare things that can happen. But basically, these cells are found somewhere else. And so, if you think your periods are bad, imagine that period tissue is also somewhere else, causing inflammation and pain. So commonly, people have very painful periods, and so it's not normal to have your period and miss school, work, throwing up. Like, that's not normal.
Right.
But if you're in a certain family where maybe because some of these things definitely have a genetic and a family history component, your mom, your grandma might say, oh, it's just the way it is, honey, and prepare you and just deal with it and make it, normalize it, right? Same with the bleeding. Oh, honey, that's, me and auntie and all of them have had the same issues. It's just normal. Right. And fibers are super common, particularly in Black women and other women of color. And so, we just normalize it. So we need to recognize what an abnormal period is early on, as early as, when the period starts.
Right.
Right. And so once we kind of figure out what's normal and what's abnormal, then you can kind of know when to come in to see a doctor. And then the doctor can, kind of go through the things that could be happening. Common, uncommon, and do some tests that can help to figure out what's going on. So that's where I like to start, is just like from the beginning, from our family. We need to be talking about this in these forums, but also going out and asking what our family history is and figuring out what you need to know to prepare yourself when you go into the doctor, because they're going to ask, about your family history.
If I can really quickly, you're making me think about when we had our long COVID conversation. Dr. Zai created a COVID symptom tracker. And so you're making me think that maybe we need to, when we're addressing community and we're talking about what is a healthy period and period positivity, is there a way that we could educate the audience now on how to track what this looks like? Because from what I'm hearing you say is, one person could say, in September, my period was normal, but then when I got it in November was something different. And so it's having that acceptance to, or willingness to see that something's different. And to your point, saying something, right? So maybe it starts with us first, because a period is that's private for some people. They don't want to talk about
Right.
it.
Yeah, sure.
So for young people or even some adults who are watching, how would you suggest tracking that? What ways could folks start to think about, tracking their periods and whether or not these are normal, to your point?
Yeah. So, it's a little hard to measure how much you're bleeding. There's so many different ways so many menstrual products available, pads, tampons, cups, etc., period panties, all these things. So it's a little bit difficult to quantify how much blood is happening. But in general, let's say you're wearing pads, you shouldn't be soaking through a pad in an hour. That's not normal. Usually the average period is anywhere from 4 to 7 days. More than 7 days is probably abnormal. And then if we really take it back, our governing bodies for OBGYN really encourage us to say to patients that it's really any symptoms, bleeding level that's disrupting your quality of life, right? So it's about your quality of life. So that going back to missing work, missing school, missing social events because you're afraid that you're going to bleed through your outfit. I work closely with a patient advocacy organization called the White Dress Project. And I guess you probably guess why it's called that. Whether you wear dresses or pants or whatever, it is for someone with heavy menstrual bleeding, heavy periods, they don't wear white. They are afraid to wear white because you never know if they're going to have an accident, And so that advocacy organization really focuses on increasing awareness about what's normal and what's not normal through that symbol and through just kind of getting out there and speaking to the community and having conversations like these.
Right.
Yeah.
There are some apps actually that
Well,
you
there's
can
apps,
look
yes.
on the app store, like
Yeah.
on my own phone, like you can track your flow, you can rank how heavy, light. So if you have a phone, some people don't have phones, but if you do have a phone, there are some pretty good apps these days that just help remind you.
That reminds me of like if there's any significant change also, right? So like you could be someone who bleeds for 2 days, but now you're bleeding for 4 days. And like I said before, 4 to 7 is kind of normal. Well, if you went from 2 days to 4 days, for you, that's not normal, right? So things like that. And these apps actually, I have one too. Ovia is if you want to pay me for saying it,
You're going to have to pay them. You're going to have to pay them.
but yes, these apps really do help to kind of track symptoms, track frequency, associated symptoms too. So like if you're not just the amount of bleeding, but if you're having pain, diarrhea, gas, bloating, these other things, pain with intercourse, pain with sex, those kind of things are really important to take to your doctor's office and say, this is what's been going on. So those apps aren't just for fertility.
Right.
They can be used for other health conditions.
So say if there was a young lady who expected that she have had some of these symptoms, and she went to her doctor, what tests would she ask for?
Well, are we talking like PCOS symptoms or heavy periods, like
Okay.
period problems?
So say if she say that it's not too far off from her normal situation, but she has noticed a little bit of say pain, like you said, during intercourse, and she's been afraid to go, but she knows that she should. What would she say to her doctor to either find out if it's if she went to you, if it was either endometriosis or PCOS? Because from our perspective, like, we don't know. Like, we just know that we feel pain and we know that something is not
it's a part
right.
of the process of having sex.
Right.
So you're
Right.
associated with the medical condition.
I see what you mean. Yeah.
Right. So so what would you ask for in order to get like a proper diagnosis?
Well, a lot of it, when you come in, you're already saying that you're going to talk to me, you're going to tell me all about what's been going on. I'll ask you more details about how long has this been going on. Does it happen with every partner? You haven't, have all of these things will then lead me to kind of think about what steps we should take.
Right.
Often a physical exam is really helpful to see if some of the symptoms that you're experiencing with certain activities, whether it be physical activities, sexual activities, can be reproduced on exam, either by doing an exam to feel the uterus, feel the ovaries, just feel the pelvic floor muscles as well, because some of these things over time can really affect the pelvic floor muscles as well. And so sometimes a physical exam, although uncomfortable, can be really helpful in kind of trying to pinpoint what might be going on. After that, lab studies. So there's not really any labs that are going to help you to diagnose endometriosis. In terms of abnormal periods, there are certain tests that we can check. First of all, if you're telling me you're bleeding through your clothes and you're dizzy and lightheaded, I'm going to want to check your blood counts to see if you're anemic. So we can check for a complete blood count for anemia, maybe some iron studies as well. And then if we're looking at different hormonal causes, there's a lot of different things that can cause irregular or heavy periods. So we check a thyroid, a prolactin, which is a hormone produced in the brain. We can check estrogen and progesterone levels. There's also some other kind of enzymes and deficiencies that can also be abnormal. Of course, we're going to check if we're concerned about irregular or infrequent periods. We might check your testosterone levels, both the ones that are produced by the ovaries and the ones that are produced by the adrenal gland, which is another little. I know there's all this stuff that our body does. What else do you want to order?
I would.
Sorry, I'm taking your.
No,
I just had a thought that I think I had a couple thoughts listening to you talk about this from a gynecologic perspective, and I'm talking now as a woman.
Yes, ma'am.
It's not easy to talk about your bleeding.
I'm telling you.
Like, you don't want to talk about it sometimes. So I would say to like the listeners, like, that's kind of normal for those of us who are shy. Who you're talking about your vaginal bleeding.
Right.
And then you go see a doctor, and it's not so much, I think I would say to someone, like, be prepared to, be as trusting as you can be and be as honest as you can be. Because, like, some of the questions that I think would come out of the visit is, do you have sex? Do you have sex with men, women, both? How often are you having sex? And is it painful every time? Like, these are hard questions, but important ones for you
right?
to learn about whether this pain is normal, isn't normal, what kind of sex, penetrative sex, anal sex, vaginal sex, oral sex. I mean, it is not easy.
Are you sure you're not a gynecologist?
No, but I care about women's health a lot, and I care about women a lot, and I care about women of color a lot. And I think that we need to communicate to women of color that it is safe to talk to us. And it's on us to like develop that psychological safety with your provider. And if you go and see someone and you think they're blowing you off or they're a little bit short, find someone new.
Oh my gosh, I spent my life with going to the doctors.
Someone new.
So
Or
much
ask a
third
friend.
opinion.
Ask a friend, who'd you go to that you liked? Not who'd you go to, but who'd you go to that made you feel comfortable enough to talk about your sex life and your vaginal bleeding and your boobs. Like, it's not easy to do that. So it's like,
true.
find people like Dr. Noel, like, who is going to care a lot about hearing and asking hard questions and getting real answers. Yeah.
That's good.
I think another thing is for our audience to remember too is that this is you guys' life. Like, I'm sure you've heard so many stories, and you know, this is not something that is out of your jurisdiction. You know, so like you said, be honest. Be honest, guys. They're here for us. I might switch my provider to these ladies over here because I've been having a hard time personally too.
I'm sitting here and saying to myself, first of all, thank you for your energy.
Yes.
Because I know for a fact it's resonating. That is without a doubt. And then not just your energy. We were talking about this before you came on and before we went live. When people in your specialty leave your office, leave the hospital, and come into community and have these type of conversations to this level of understanding, it means something to people in community. Because for so many people, there's there's them and there's the others, right? Or there are people who put you in this box of they don't believe you to begin with because you have this medical history of always saying something. Something's always wrong. So for you to come and speak to community at this capacity, it says a lot about your character. And shout out to BMC, first of all, for housing you, because I know for a fact that this conversation is going to lead to people wanting more information, wanting to Cricket's point, should I be switching my provider? Because if you do not trust your provider to ask questions that are meaningful to you, you need a new provider, right? And so what I'm grateful for with MA-CEAL's partnership with BMC is that we can do this. We can bridge the gap between community and providers such as yourself so that people can see that we're here. We're located locally, and you're accessible. So thank you again for being here, because for so many, this conversation doesn't happen. And so that's why we're grateful, too, for our partnership with Show and Tell Boston, is because when Jasmine and I thought about this idea, we're thinking about the people who aren't just shy, but that mistrust is embedded in their health outcomes. And so, again, at the end, we want you to let folks know how they can reach you in your offices. So that way, if they want to ask more questions that are more personal, things obviously we won't talk about here because of HIPAA. We want to make sure that folks can find you, because we don't want to just have the conversation. We want to make sure that we're lining folks up for support. So again, thank you for your energy.
Yes. I think it's really important, and I want to say on the record, I'm here.
That's right.
And I care more about doing things like this out in the community than anything else, because again, I feel like the onus is on us as doctors to get out of our clinics and get out of the hospital and go to the street and go talk to people and be real.
That's right.
And I tell my patients, I just don't think society has treated women and women of color like they are worthy, that they are valued, that they are appreciated, that you should be getting everything you deserve. And so I'm like, when you step into my office, I'm going to make you feel like that. And especially...
I ain't even in the office and I feel
like you, but if I do
I think that's important, because you don't usually feel like that. You don't usually feel like people are working for you.
That's
literally.
Right.
And I expect my clinic, if you have breast cancer and it is scary, that we are working for you, man. We are working hard. And it's because you deserve it.
That's right.
You deserve, and it is amazing in my 10 years of doing this, how often the women I see, and I tell them that, they're like they don't believe it. It's so sad. I'm like, no, you deserve it.
Right.
Yeah.
You deserve the best care.
That's what's up.
You deserve the all-time best care.
Right.
Come on.
Right. Thank you for
And
saying that.
it's just so sad sometimes. I want people to know that.
Yeah. Thank you for saying that. Okay. I feel good. I know who I'm calling on Monday morning. Can we talk about how stress affects our bodies and our hormones? Oh, man.
Now that is a great question.
Yeah.
Because there's definitely a relationship between stress and how our bodies perform and function. When you think about stress, there are responses that you'll read about in the textbook. Cortisol levels get elevated, and that causes this and that, right? There's also a concept that I like to talk about a lot, especially when I try to explain to my Black patients why they're getting fibroids that are larger, more numerous, and diagnosed earlier than their white counterparts, and that is the stress of racism.
Oh, I didn't even think about that.
Yeah, I said it. So there's a term called weathering, which is basically the process. It's of the impact of stress on our bodies over the years and how that impacts our health outcomes. And so it's not exclusive to fibroids. That's just kind of what I live and breathe a lot. But certainly you could think about other conditions, cardiovascular health, metabolic health, cancer.
Breast cancer. Yep, definitely.
So absolutely. And so stress, I mean, what does that mean I can't help that I have to work 3 jobs, or that I
Right.
have these kids running around,
right.
or like stress is all over and in different
Right.
forms.
Yeah. Oh my
And
gosh.
so, how do we manage stress? Is there something that I can do right now
Yep.
that's going to decrease my risk for certain conditions? And I mean, it's hard because a lot of these things are kind of things that happened now in our lives,
Yep.
maybe happened in utero. And I know,
Ooh.
or like when we were in our
Yep,
mother's womb.
Yep. Yep. Talk about it.
That is that a contributing factor?
You know, the answer is yes.
Whoa.
Yeah,
That's wild.
it is. And so, yeah, so it's a lot that we have to manage. It's not just taking a pill or exercising.
Right. Oof.
There's a lot of other things.
Dr. Noel, you're making me think about what we as Black and brown women know as the mother womb. When you talk about
See, there's a
this
word
this
for it.
transfer trauma that happens in utero, and so for people who may understand it from a different perspective, it's what we know as the mother wound. And so sometimes people think it's the way she raised me, it's the way, the things that I'm learning, it's what I was given or I wasn't given, but a lot of these things were embedded from when you were in utero.
Yep.
And so
Yeah.
oftentimes for some families that are really in tune to what this mother wound is, there are incidences where folks will say, well, she has that same trait as her mom and her grandmom. And so these are things that, culturally people can understand. But we need to know from what you're sharing with us is that these very things are stressful. And what we also know them as is the Black savior woman complex of we can do all the things. And so learning when to give yourself grace, learning when to pause, learning to exercise your no is what I tell my daughters. And so I think it's important for people to hear that.
Yeah.
That we have to, if we don't create space for ourselves, no one is going to do that.
Absolutely.
And so I thank you so much for saying that, because there's the mother wound, and I guess at another time we'll talk about the daddy wound, but in particular, there are a lot of things genetically that we carry that a lot of people aren't aware that they manifest in different ways.
Yeah.
I wanted to go back to Dr. Coe about we know that at 40 we have the screening for mammograms for breast cancer, but when we're talking about our young people who are engaged in sports and they're active, or they might be expressing chest pains or things, how can parents consider these health conditions or even risk factors to possibly put things in perspective to ask their doctors about, this is a concern that's been consistent? Because if the child is playing sports, we're going to associate it with that's where it could be coming from.
Right.
How can parents of young people, what can we do to know about when we should start this screening, or even having this conversation with our daughters, nieces about, breast health and all the things?
Yeah. I mean, I think that a lot of times people will make up reasons for things in their own. Like, I'm having chest pain. Oh, it's the soccer game that or it's because you, and people have a because. And when it comes to breast health, if there's anything if it crossed your mind as, is it normal? And you have to ask yourself, please go see someone. That should be the bar. It's like, if you thought, I'm not sure if this is normal, hey, go see someone and ask. At any age, you should do that. And then the second thing I would say is definitely at 40. I don't care. Everyone at 40, and this is for this community of people, women of color, please, like, there's don't wait. And I'll throw in for colonoscopies too. Okay? I'm gonna throw that colonoscopy recommendation out there. 45, go get a colonoscopy. 40, get a mammogram. 45, get a colonoscopy. And
Cervical cancer
definitely,
screening?
yes, cervical cancer
Age
screening.
21?
21.
gosh.
Whoa.
That's when
Age
you're supposed to
21
start getting
is
your
when
pap
you should
test.
get your-
Pap test.
Y'all hear that?
Yeah, 21, 40, 45. Those are
All right.
my favorites to get. Pap, mammogram, colonoscopy. Please, everybody. Take care of yourselves.
Right, that's right, take care of
but
yourselves.
prevention is worth everything.
This was good.
It sure, Liz. I don't want you to leave, Dr. Noel. You sure you got to go
know.
get the baby?
I do like. I love this, and I would love to stay. I would love to stay. We can do this again.
Oh, we have to do it again.
Okay.
Is there anything that our audience should know as it pertains to endo or PCOS that maybe they shouldn't, that is super important, maybe that's like a myth or anything in alignment with the knowledge about these two diseases that the audience should know?
I think that going back to just kind of talking about it in our communities
Yeah.
and starting to understand what's normal and what's not normal,
Yeah,
and
yeah.
if there's that, is this normal? Then just get checked out and get seen. And a normal period is a little bit of something that's hard to define at times,
Right.
in terms of, because no one's sitting around in the bathroom like showing each other pads and
Right.
saying, but just understanding your body, tracking your symptoms over time, what's normal in terms of the flow that you've been experiencing, any changes over time, and is it impacting your quality of life? One thing about these conditions that is, it's not cancer, but I like to say it's not cancer, but it's also not benign, meaning that these things do have significant impact on your quality of life and can be life-threatening. If you're bleeding to where you're super, super anemic and your heart is straining, and, these conditions can be life-threatening. And so just keeping that in perspective, that we can focus on things that impact our quality of life, and it's okay to ask.
And for the women that are watching this right now and they like, I would love for her to be my doctor, how could they reach you?
Well, I work at Boston Medical Center, and do you want me to say the clinic number?
Please, if you can, if you're allowed to.
617-414-2000. I don't I'm not really big on social media myself personally, so I don't really have a website. But if you were to look up BMC OBGYN, you'll find me.
Awesome. Thank you so much. All right, guys, that wraps up our first part of our Women's Health episode. We'll be back soon. Thank you so much.
Thank you.
What's up, family? Welcome back to Show and Tell Boston, where this episode we are talking about women's health. I have my co-host Shakira. She's still here with me. We got Dr. Cole. She is busting it down with the knowledge, honey. Thank you so much. Seriously, I truly mean it. Yeah. And we have our beautiful new guest here. Her name is Dr. Joseph, but I want to have her introduce herself and her specialty.
Yeah, thank you so much for having me.
Welcome.
Sorry I missed out on the fun earlier. I'm Naima Joseph. I am a maternal fetal medicine specialist, which means that I take care of high-risk pregnancies, and I see people at Boston Medical Center. And I'm happy to be here. Thank you.
Thank you so much. And we must say that Dr. Joseph is on call, y'all. She is not playing. She cares about, look, she's here for the community, but she still has to work. So if you guys see her get up, that's what that reason is for. But let's start with women's maternal health. What is it and why is it important?
Yeah, so I'm glad you asked that question.
Yeah, I like to get down to the nitty-gritty, the roots.
Because maternal health doesn't start when you're a mom. It starts preconception. It starts when you're thinking about becoming a mom, with all the things that you guys talked about before, about making sure that you're healthy, getting your preventive care, making sure you're staying up to date with your pap smears, as was mentioned. And then as you're entering pregnancy, all the things that have to do with making sure that both patients, the mom and the baby, are healthy. And then, as we know in the United States, when we think about maternal health and the crisis that we're in as far as poor outcomes for moms, especially Black moms, knowing that some of the after effects of pregnancy or the complications that can happen in pregnancy actually can last for up to a year after you give birth. And so it's the whole thing. It's from, preconception care, the time during the pregnancy, which is really only in the 9 months, and then the year after that, and then going back and continuing with preconception care or preventive care until the next time that you're pregnant.
Whoa.
That's a lot.
Wild.
We do a lot, guys.
So whatever issues you're having during your pregnancy, after you have your baby, you can still be experiencing those symptoms?
Right. Like, we know that Black women, right, higher risk of preeclampsia. And we talked about this a little bit in between, but we talked about all the things, all the exposures, all the, the strong Black woman complexes that we have that lead to Black women having preeclampsia. But then after you have preeclampsia, we say, the immediate treatment is for you to give birth. But the risk of preeclampsia, like heart disease, heart failure, things like that, that happens for a year up to 5 years after you've given birth.
Wow.
Heart disease? How does heart disease and pregnancy relate?
Yeah. So when you're pregnant, and I always tell my moms this, it's like, you are growing a whole nother human being.
Right.
And that's a lot of work. And it is a lot of work on your whole body, but your heart especially. Your heart having to take care of all the extra blood that's made to support a growing baby. Which for some people, they do great. For most people, luckily, they do great. But for some people, they develop complications like heart failure, like preeclampsia, et cetera. And they might make it through the pregnancy okay, but they might still have complications from just having hypertension down the line, as well as other heart conditions that can happen.
Is there a specific age group that you're seeing these risk factors in when it comes to mothers, specifically women of color? Is there a certain age group that this is most prevalent in?
Yeah, that's a great question. We usually say that as far as the ages, it's either like you're super young when you're pregnant or you're a little bit older when you get pregnant. So, the young moms out there, 19 years or younger, getting pregnant, as well as older moms, 35 years and older, getting pregnant. That's kind of the highest risk. But really, even when you think about all the people that are, at risk, it can be really unpredictable. And so really, like anybody has some level of risk for developing preeclampsia, and that's why prenatal care is so important.
Could the child experience what I guess kind of maybe talk about the mother woman that we were talking about, but could the child be experiencing direct symptoms of what the mom is experiencing in utero?
That's a great question too. And I was talking to Dr. Cole a little bit about some of her work around the genetics of cancer, and I think the genetics of pregnancy are still not known. But as I was telling you, and for all of us women, when we were little embryos inside our moms, when they were fetuses inside their grandmothers, all those things can lead to genetic changes that can lead to different kind of risks for us to develop preeclampsia. As far as just in the moment that you have preeclampsia, there are some risks to the baby because, like I said, the immediate treatment is that the mom has to give birth. And so if you're premature, then now that baby is exposed to this risk of prematurity. And of course, that depends on how early in the pregnancy the baby needs to be born.
Oh.
Yeah.
I'm a professional makeup artist, and my specialty includes nails. And I actually remember going to Boston Medical. I had a client who requested nail services, and she was about 5 months pregnant. She had 2 children prior, and she said both of her pregnancies before that were beautiful, but she said during this 5th month through her pregnancy, I can't remember exactly, but something had separated from, like the uterus had separated from the
Placenta.
Yes. And she had to pretty much stay in the hospital up until they said it was either okay to go home or up until she gave birth. And I just found that so like that can happen? Like what?
I know. I mean, for most people, pregnancy luckily is uncomplicated, but there are, my subspecialty exists because we just need to make sure that everyone is aware about what the risk factors are, what to know to come in for, what to tell your doula, your midwife, your doctor, et cetera, and when to come in and get care.
Dr. Cove, do you experience a lot of do you take care of pregnant women with breast cancer?
It happens, and I have taken care of a woman with who got diagnosed with breast cancer during pregnancy, and there's a definite there's a lot we do know about when we can or cannot administer chemotherapy, when it's safe, when it's not. It's very complex, and we have to really work very closely with our excellent colleagues, and we get it done. I mean, we get it done. The patients that I have taken care of, I can think of two right off the top of my head, are alive and well today.
Oh,
So,
praise Jesus.
and yeah, their babies are healthy, and
I think
it's
the
not
big-
easy,
yeah.
but it can get done.
Yeah.
Yeah.
And just because you're pregnant doesn't mean that you don't get all the things that you're supposed to get, like
Right,
your
right.
cancer care or screening or
Yeah.
other things that you're supposed to get. It's just how do we make it safe for you and the baby?
Wow.
That's right.
Wow. And
Oh my God. I need to pick my jaw off the floor.
Yeah. Yes. Yeah.
I'm thinking about the overall mental health of a woman who is pregnant and is diagnosed with breast cancer during pregnancy, and going back to what we talked about, this transferring of things from the mom to the baby. And so, can each of you talk about what that could look like for our members of our audience who are listening, because I could gather that there's someone who may have been diagnosed during a pregnancy or prior to one and is afraid to give birth or get pregnant. And so hearing you say that those two women thankfully had safe pregnancies, is that safe pregnancies common for someone else who could potentially be diagnosed with breast cancer during pregnancy?
I think that in the hands of expert care, in the hands of providers that communicate well together and collaborate well together, there's a lot we can do.
Yeah.
And I think
Absolutely.
faith in that is important. And not everything works out the way we want it to. We've seen tragedies occur. Some things we can't save.
Yeah.
And that's real.
Yeah.
So I don't want to paint a picture like everything's going to be okay. But we try the best that we can. I tell my patients, I can't promise you that I can cure your cancer, but I can promise you that I'm going to work my hardest.
That's right.
Yeah.
And that's what we can do. So, yeah.
And you talked about the mental health aspects of cancer diagnosis or any of these, complications that happen during pregnancy, and that's real. And, I think slowly there's become more of an acceptance around therapy and taking care of your self mentally during pregnancy. A lot of that, too, is about taking care of yourself and your community taking care of you, which, we're working towards that as well. And so it's just important to really stay on top. Just as I talked about, pap smears, blood pressure, things like that, staying on top of your mental health for everyone, just during pregnancy, before pregnancy is so important.
I think this is a great segue here.
Are you in my head? Too good.
Y'all might have to hire me as your third. Your third co-host. Sorry, Tata.
Where's the contract?
Show me the contract. But I'm going to go ahead and ask this question.
Please.
So we have here, what role does clinical trials play in improving breast cancer treatment outcomes for Black women, and how could more Black women be encouraged to participate?
Hard question and a really important one.
Right.
I explain it this way to patients. Medicine and science needs people willing to help us learn. And I've told my patients everything I'm recommending came from women before you that were brave enough to sign and say, I will try that and see. And I know a lot of people in the community think of it like, I don't want people experimenting on me. And I want to acknowledge that has happened and that is wrong. And society has tried to right that wrong. But if you don't embrace clinical trials today, then our people of color, our communities of color are going to be hurt even more. So let's talk about what happened with COVID, for example. That's a good example of people being scared of medicine or scared of science and thinking, I don't know. We have been victims of a lot of abuse in the history of medicine and experimentation. I'm not willing to do the vaccine. I'm just not going to get it. Well, guess what? Unfortunately, a lot more of the humans and people in communities of color that were mistrustful hurt the worst from the virus itself. And I think that's a similar parallel
Yeah.
to what's happening in cancer, and specifically breast cancer, which is what I care about. Is if Black women don't engage with the science, and that means engage with the clinical trials, then we're not understanding breast cancer for you to help women that come after you.
Right.
And
makes
you want to
sense.
be part of the chain of learning and education and science for all women, for yourself maybe, but really for the people that come after you. It's a generous thing to do. It's a hard thing to do. And it's an important thing to do, and it's not for everyone. So I try to say, you can say no. That's okay. I respect that. But give me the chance to explain it
Oof. Right.
so you can have that choice. I honor your choice. That's what I think.
Dr. Cole, while we're here, I want to mention, as a community activist and a public health professional who works closely with the community, I recently met a young boy, African American, who is 12 years old, who knows for a fact that he wants to be a part of this medical science world, because he has a personal story where he has a sibling that has a rare form of cancer. And he knows already at 12 that he wants to become a doctor, a scientist specifically researching cancer. And so when you talk about these clinical trials and this, the what you know comes from the women before the woman who's at your office that day, it makes me think about the people who are eager and ready to be a part of this community. And so for those of us, those who are watching, if you're interested in a clinical trial, although we're not promoting it here, but what I'm saying is, it is safe to know that there are people such as yourselves that our audience can get in contact with, to be able to see if this is something that they might be, willing to participate in. I also want to plug in one of our partners, which is the Clinical Research Network. That is a group that will come in and educate about all the components of research to make sure that the community is aware. Another piece that I think about often is, we think about research and we quickly equate it to Black people and the historical harm that has happened. But when we think about the spectrum of people who are impacted by research, it is just not, it's not just Black people. I'm thinking about those linguistic barriers for those of us who have got, when we think about those things. So I know one of our questions is, what barriers do you both see in your work? But I just wanted to make sure that we let the community know we hear them when they say, not me, not research. But I also want the community to hear you say that today, scientists over the last so many years have been working to right those wrongs. And so thank you for saying that.
Yeah. Well, for the barriers question, I like to say to people, I don't treat breast cancer. I treat the woman who has breast cancer.
That's it.
So you come in your full self of who you are, and I work with you. And every individual has barriers to their understanding, to their level of education or knowledge around science and terminology. And can you explain that? Like, I don't really get that, doc. And I'm like, let me try to say it this way. Let me try to take the time so that you can really understand culturally.
That's right.
And I understand you. Like, I want to understand you so that I can help you understand me. And all those, cultural, religious, language barriers, age, different ways, belief systems. And I think we work really hard to see people and honor that and ask good questions and thoughtful questions and invite people to ask us questions. That's how we'll get somewhere together.
I also think more and more, medicine is not about you come see your doctor and your doctor hands down information. It's about where are your sources of truth, who are all the people you're listening to, and how can we engage everyone. Like, hearing your work actually is so inspiring because it's partnership such as that really helps us all kind of create this community of trust. So that way when we're talking to people about research and engaging people, one, they see people that look like them doing research, but also they get it from all different sources of people that are working together.
Wow.
Yeah, that's amazing.
Yeah.
Because you kind of don't really work with your doctor from my experience, they kind of just tell you
Yeah,
what it is
right.
and tell you what to do.
Right.
And it's like, well, I've been myself for the past 32 years.
right.
I got something to say
Right.
about me. I
Right.
understand your perspective, but
Right.
I'm me, and I know my body, me most specifically. And when I'm, like you were saying earlier, you don't have to, it's hard to realize that you don't have to worry by yourself whenever you've gone to these appointments and you get there and it's taken 3 months to get it, and you waited an hour and the doctor sees you for 5 minutes and you feel worse than you did when you came in.
Yeah.
And that's the hardest part.
Yeah.
It's like, dang, like,
was
what do
helping
I
my
do
mom
now?
too. Yeah.
Like, it
Yeah.
stresses you out even
Yeah.
more.
Yeah.
You know?
I'll add to that one of the things that I love doing in my job is that we're a teaching hospital. And so we have residents and fellows and medical students. And one of the things that I think is important for people to hear is that we as doctors have our like checklists of things that we are worried about. Like someone comes in with chest pain, we think heart attack.
Right.
Someone comes in chest pain, and we're already working hard at making that list of what do I have to worry about as a doctor so I don't, goof or make a mistake or not diagnose something extremely important. That's over here.
Yeah.
Okay. Over here is the patient.
Yeah.
And what the patient is worried about is I can't get my kid at the bus stop on time. And I have this chest pain, but I've had it for 10 years and I just want to get out of here. But we're thinking, is it heart attack? Is it heart attack? And there's a disconnect. So what I try to tell my trainees is you got to manage your worries and we call it a differential diagnosis of what you're thinking about in your questions and in your exam. But at the same time, you got to be listening because the thing that you're worried about is not likely the thing that your patient is worried about. So don't ever leave the room until you've addressed what your patient is worried about, even if it's not what you're worried about. And I think that's the way we get better at being providers, especially for communities of color, where you don't have society has not given you agency to advocate for yourself in such a strong and powerful way. You're going to tend to go home and be like, oh, that felt bad.
Right.
That felt bad. And I didn't get my questions answered. I'm not going back.
Right. I'm not going.
I'm not going to bother.
Literally.
Why would I go back? People don't hear me.
Yeah.
Right. Yep.
And I'm like, shoot.
Yeah.
We just goofed on that.
Yeah.
We got to fix that.
Yeah.
Yeah.
Thank you for saying that. Thank you for acknowledging that.
Yeah.
Dr. Joseph, it's hard giving birth in this country.
Yeah.
As a black lady.
Yeah, it is. I know.
Why? From your experience, like, why are black babies infant mortality rate higher than, say, a Caucasian baby or a baby from another ethnicity?
Yeah. I mean, we know why it's racism and how that racism is
The fact
just
that it is
pervasive.
why does it
It is,
exist?
Yeah. Yeah, it's pervasive. And so when you think about, when do you initiate care as a black woman compared to your white counterpart? That's gonna later, right? Because maybe you're going to the hospital where the access to prenatal care is just there's so many people, so it's hard for you to even get a visit, or maybe you live somewhere where the prenatal care access is 30 miles away, and so that's just not going to happen. And then, in addition to that, all those barriers have created probably a higher chance that you're going to have some complication.
That makes sense.
And then access, complications, and then like I said, we've had this approach in medicine where it's like, I give you. And so patients not having resources in their community, patients not having education about things to look out for, patients not even having insurance until recently for 6 weeks after they gave birth and not even having ability. Yeah, so that's new is that, many states have expanded insurance access that you can get care for 6 weeks after you give birth to up to a year after you give birth. But like I said, if you have preeclampsia, right, and you have risk up to 5 years and you lose your insurance, then what does that mean? Nothing. And so, yeah, it's hard. And all those kind of structures in terms of healthcare access and likelihood for having these bad outcomes all come down from racism. The system was meant to be that way.
it's making me, Dr. Joseph, think about the women who are probably watching and saying, you know, when I go to my doctors, I'm not even believed in the first place. Like,
Oh my
right?
gosh,
Or
yes.
They think,
Yes.
you know, they think that
Yeah.
I'm just saying something. They're telling me
Or
what I'm saying. They don't see it.
Yep.
And so there's that aspect where
Yeah.
women of color are not believed
Yeah.
when they go to the doctor's office.
Yeah.
And so therefore we're probably not going to go at all.
Right.
Or when we go, we're not going to say the thing that is wrong. I'm
Yeah.
thinking about that little chart that's like, at what level is your pain?
Yes,
And you're just
yeah.
like, you're going to go with the lowest one because
Yeah.
they're not going to believe you
Right.
anyway.
Right.
How can we encourage those who are watching to still advocate for themselves, to
Yeah.
have that sense of agency to speak up in these doctors'
Yeah.
offices and say, actually, this is what's happening to me.
Yeah.
And then, Dr. Cole, you talked about this earlier about, you know, when we're not receiving that care that we're looking for, that we deserve, let's reiterate what that looks like for the patient who might be experiencing this not believed. So Dr. Joseph, you can speak to that first for the women who might be dismissed about their symptoms, and then reiterating what you said earlier.
Yeah. Thank you so much. I think that this is probably like the most powerful thing that you can do for yourself, your health, and your pregnancy is advocacy, which I think that's hard, right? Because if you know you're going someplace where they don't even listen to you, then like, what does it mean that you say things? But one of the things we're doing at Boston Medical Center is we have a program for people where we give them a blood pressure cuff and connect them with a nurse, and the patients monitor their blood pressures, right? And for me, you know, I had come from a different place that had also been giving out blood pressure cuffs, right? But what's different in this program is people being given a language through this amazing nurse named Megan O'Brien about these are the tools, these are the things, this is how I help you translate this so that you can be believed, which is sad that that's where we are. But for people to have a tool to say, hey, no, I've been watching my blood pressures. I know what's normal for me. Here, this is what's normal for me. This is what I'm telling you is not normal. And I know my body.
That's right.
And being able to be given tools for self-efficacy and for self-advocacy is so important. And I remember even for when I was pregnant and I had preeclampsia, and I was just like, oh, I think I'm okay. Oh, it's weird. I used to be able to walk to the park. I can't walk to the park, but I think I'm okay. Like, and then telling my friend was also my doctor. She's like, yeah, you're probably okay. And my husband was just like, get to the hospital. Like, what is wrong with you? And then so having in addition to you being your advocate, but your partner, your family, your sister, your mother, whomever, having support staff so that they're like, I'm looking at you and I know that this isn't right, and I'm bringing you to the hospital. Because when you are the person taking care of yourself, your baby, that's too much.
Gosh.
Right? And so,
Tell me about it.
yeah. And so as much as you have community, I think that's why doulas are so important too, because having people who are in the community who know you, who've known you before your pregnancy and afterwards to help advocate is so critical. I should say that nationally there's a lot of work being done about how do we train OBs, which I'm embarrassed, but how do we train OBs to actually hear patients? And it's a campaign funded by the Centers for Disease Control and Prevention called Cure Her, which is about, you know, the story is unfortunately from moms who have died, who every single surviving relative has talked about patients coming to the ED, patients telling them their story and not being heard.
That's it. This is we got work to do.
Yeah, yeah.
Come on.
I think if you don't feel like your provider is meeting your needs, I would say it's hard to ask patients to say something to that provider directly. I just don't feel like that's comfortable.
Yeah.
And people generally won't do that.
Yeah.
Like you won't feel like, unless you can say it in a way that's like, I don't think you're hearing me.
Right,
Or
right.
I'm not sure you heard me.
Yeah.
Or can we take a pause? And can I say that one more time? Because I don't know if you heard me. Like little things like that, that would be step one. I think step two, after you leave, is to talk to your trusted people. Like the people you trust and say, I had not a great visit. And sometimes people will be like, oh, well, I love my provider or my friend has a provider they really like. And it's a fit. Sometimes it's a fit. And some people are like, I'm not a perfect breast oncologist for some people, and they prefer my colleague. And the other, patients that have transferred over to me. Sometimes it is a fit issue.
Right,
I think we should acknowledge that.
Yeah.
We can acknowledge that, right?
Yeah.
And then finally, there is a great patient advocate office at BMC. And I have actually referred my own patients there when they've had other, unhappy encounters where they want to hear. Because sometimes when you have a third party collecting, patterns of complaints, that's a teachable moment.
Ooh.
That is a teachable moment for the provider. Actually, it's a gift. Feedback is a gift.
Yes. Oh my gosh.
Feedback is a gift. So if you
Actually,
didn't
we
have
should
one,
tell patients that,
That's
right?
what I'm saying. Yeah.
It's true. About FIT because I'm on call, so I was on service and seeing patients in the hospital, and she told me like the way you said that, like that made me nervous, and I was like, oh my god, like that's not my goal, right? Like, and I want to do better. And sorry that you're teaching me, but it is a gift.
It's
and,
a
and most doctors will not. Most clinicians will not take it the wrong way if you're saying, here's how you can be better, because everything that I do is for you to be better, right? Like, and so we want to get that information. So I just want to highlight that you said, like, you're not hearing me, and feedback is a gift, because it can feel like with that power dynamic that you really are not the one that can give that information. But actually, like, we want it.
Yeah. And I think, just to be perfectly honest, like, not all providers are that good.
We want it.
We want it. Like, we want to know. And also, if you're a provider out there and some patient tells you, I don't think you're really understanding me, then don't take it personally. Don't take it personally.
Yeah.
Like, try to learn from it.
Yeah.
I think that's a better way of anything in your life.
Yeah.
Right?
Right.
So it's hard.
Effective and honest communication.
Yeah.
Is there like a resource or like a huddle? I don't know what it that you all could like communicate and like teach one another or share experiences one another in order to get like a better understanding of patients and how to listen to patients outside of projects that are getting funded by the CDC.
Yeah. So I'm bragging on BMC.
Yeah.
But we do have a whole kind of accelerator that's geared towards community engagement.
Okay.
Community advisory boards that really help us and dictate what the strategic goals are for our hospital and for even different programs within, and help us understand really where we should be moving in terms of community alignment and engagement and priorities. And so, yes, on the research end, most clinical trials have a CAB that helps inform kind of the goals and the objectives and the outcomes that are meaningful for patients. But same on the clinical side, through patient advocacy, through our community engagement activities. And most hospitals will have some form of patient advocacy. I just think that BMC does it really well.
That's what's up.
You talk about patient advocacy and the community at BMC. One of the questions here is related to socioeconomic status. For breast cancer and both for maternal health, how does socioeconomic status impact the quality of life for your patients?
In every possible way. In every possible way. I think from insurance and access to care, in copays and financial toxicity of cancer, which is a whole field of research, is, how much savings do you have to afford to take how much time off in order to get the treatments that we're asking women to get? Oh, my goodness. It is now in breast cancer, if you come to us late in your diagnosis and you have a later stage, you will end up requiring years of treatment. And practically speaking, it's not possible to not work for years. You don't have a year's worth of life savings usually if you're coming from a socioeconomic status background that can't support that. And I feel like we should talk about that. How do we support people the best way possible?
And when you talk about postpartum care and all those risks of complications, some people are able to not work for 6 months.
That's a luxury for some.
It's a luxury, I went back to work 5 weeks. Not all of us can do that, right? And so it's and so when you're back at work and taking care of a new infant, how are you paying attention to those signs that say something's not right? How do you have the time to do that?
Especially when symptoms are so similar. So it's like, it could be this, it could be that. But because you went back to work so early or you can't,
take the time,
embrace this journey towards wellness for your breast cancer, you start to associate it with something else. So
Right.
maybe I'm just tired.
Yeah.
Uh-huh.
Or you
Yes.
dismiss it.
Yeah,
Exactly.
Dismiss
yeah.
it, yeah.
Wow.
Yeah.
Wow. That's deep.
My patient advisory group, when we met last, we talked, they were telling their stories of their cancer diagnoses, and every one of them talked about the stress around work.
Wow.
And how can I continue working, pay the bills, pay my rent? I've taken care of women who become homeless during breast cancer treatment because they really can't end up paying rent anymore and making ends meet. And they become transitionally homeless where they have to stay with a friend. And those are real.
Yeah.
And it's so hard and difficult. So I want to say that happens.
Yeah.
And it deters people from getting care. Like, why bother?
Right.
You get to the why bother stage, and that's just very dangerous.
Right.
I want to touch on that really quickly because I know that there are programs for maternal mothers who might be facing some risk. There's housing resources for them.
Yeah.
Are there resources for breast cancer patients who are now, to your point, homeless because of trying to navigate this care?
I mean-
are there resources that we could share with the community that you know of?
I mean, Rosie's Place ends up being a place I have a lot of patients who've used. Boston Healthcare for the Homeless across the street from our hospital has housed multiple patients I've cared for over the years in all cancers, not just breast cancer. And it's incredibly valuable that we have them. Our social workers are overworked. They have a lot to do and not enough resources. So I lean on them heavily, but they can't provide all the answers sometimes. And back to your original question about socioeconomic status, man, it matters at every level to their social determinants of health. You know, we have a food pantry.
Yeah.
Thank God for that.
Yeah.
I've had patients utilize our BMC food pantry like so much, and I'm so grateful for that.
Yeah.
Right?
We've even taken a walk over there and seen it. So
Yeah, food pantry. We have transportation services. We have built up as much as we can at Boston Medical Center to care for these women who are working hard or are at a level of income that's tedious. We try our best.
Yeah.
Yeah.
But I think also socioeconomic, when you think about just upstream, right? Like, we're learning a lot more about environmental exposures that predispose you, right? And where do you tend to, right? We all remember Flint. Like, it's like, where do you live and how does that impact your risk for having cancers? But we're also seeing that also with preeclampsia and preterm birth, that some exposures increase your risk. So socioeconomic status goes so much in terms of just your risk for having these, your ability to get treatment, and your ability to sustain recovery and good health afterwards.
That's right, nutrition and health. I mean, it's easier to get a McDonald's Happy Meal and feed yourself, and it's cheap, and Taco Bell, and instead of get a salad, it doesn't taste as good. You don't want to have it. You're not used to it. It's more expensive. Who's going to do that?
Right.
And we're like, oh, good nutrition. Nutrition, like salads and vegetables and fruits. They're like, not my reality, you know?
Not at all. Yeah.
Let's just be honest. Like, how do we change that? And how do we encourage people around that? It's not easy.
Yeah.
I want to plug in right in this moment the food co-ops that we have across the city. I know offhand the Dorchester
Community
Food
serving.
Co-op.
Yeah.
There's so many different places, the community refrigerators.
Yes.
And so I know pride, being a woman, not just a black woman, but being a woman comes with a lot of work. We carry a lot of responsibilities. And I know for me, when I can financially feed my kids the way I want to feed my kid, I feel like I'm superwoman.
Yes.
And so I'm so serious.
Yes, it
And
is.
so I'm
It is,
thinking
yeah.
about the moms and even teen moms who are probably thinking about, I'm not going to do that. That's embarrassing. That's beneath me. But it puts me to think about, our ancestors and our elders who, God knows what they had to do to feed us, the basic necessity.
Right.
And so I know we talked earlier with Dr. Noel about this PCOS and obesity and how those health conditions have so many different layers. But nutrition, to your point, if we do not have nutritional value during pregnancy, during breast cancer, or just in our overall lives
yeah.
in childhood, we are at more risk for other underlying conditions. And so I want to thank the community who are Advent, supporters for those who have food insecurities. Because when we think about a holistic approach that you spoke about earlier, that's one of them.
Yes.
It is how are people able to feed?
That's right.
And then I also think about the cultural aspects, right?
Yes.
And
gonna
not
say
just
that,
having
too.
the food access, but culturally,
It has to taste
do we
good.
have what we need?
Right.
The food needs to be in it.
That's
Yeah.
right.
That's right.
Right.
So, yes.
So I'm glad that we're
about
having
that.
this conversation because I
Yeah.
think it brings light to the weight of being a woman, but then also too, I think what we've done today is we provided a beacon of hope for women. And so I want to thank you all
Yeah.
again for being here
Yeah.
because it's conversations like this that are meaningful, that have a stronger impact than us just saying, call this number,
Right.
this is a resource.
Yeah.
Being able to hear you and hear your passion behind what you're saying, I think will do a thing that we're hoping it's going to do in the community. So on behalf of the community, I want to thank you for being
you.
here because, again, this is phenomenal.
Yeah.
I want to add one thing to our brothers out there.
Let's go.
Cook.
Okay.
Clean. That does not have to just be a woman's job.
Yeah.
We talk about it that way, but I
Yeah.
sometimes I'm taking a pause and thinking, dudes can cook, man. They can cook. They can pitch in. They can clean. Where are our brothers and our fathers? We help.
on.
This is not just woman's work,
That's
and I want
right.
to push back against that.
Yeah.
I love that you're stressing removing
right.
these gender biases.
Yes.
right.
Because in thinking about breast cancer in women and maternal health issues for women who are pregnant, we have to remember that for pregnant women there's the other partner.
Yeah.
Right.
right.
And so
That's right.
for the men who could be listening, what suggestions would you have
Yeah. Oh,
on
man.
how, whether it's a son, a father, a partner, how they could be helping to alleviate some of that stress that we talked
Yeah.
about, in terms of being able to put forward to a better health outcome?
Yeah. Come to the prenatal care visits.
Yes.
That's a big one.
Come to those visits. Understand what's happening with your partner's body, what the doctors are saying are concerns, and be prepared to parent. And I love it because I think so many people, at least in our practice, they come with their husbands, they come with their partners. The husbands ask such good questions because the woman is thinking about I gotta go do this, I gotta do this, and sometimes are we talking and then it'll actually be the dad that's this baby inside of you, these are the things that we need to and that's so powerful when you have. And for me, at least, to witness that too, when you have that strong, supportive person that's wanting to uplift that pregnancy, that mom, and support her. So ask her what she needs. Come to the prenatal care visits, and be helpful afterwards. Yeah.
Wow.
Yeah.
I love that. I just it makes me so happy to
Yeah.
think that if men could understand and value women to the place where we deserve,
Yeah.
we'd be a better world.
100%.
Right?
Especially now, thinking about fertility and infertility, and I forget what I want to say. I read it, but I read about a woman who could not get pregnant, and she just kept trying and kept trying and kept trying, and it was a lot of focus on her and her body when they finally got the test, and it was the man's sperm, and he just wasn't creating enough sperm.
Sure. Yeah.
And that goes back to nutrition. That goes back to like you mentioned, environmental stressors. How could what I do, breathe, eat, see, talk to, consume with all of my five senses be contributing to the health of my body, or the compromise of my body, and how could that compromise also affect my partner and our future as well too? So it's not just about us. It's I didn't make this baby by myself, nor can I make this baby by myself. So we have to work throughout this process together.
Yes. Yes.
So important.
Yes.
Yeah, I'm really glad you mentioned that teamwork. They're always with infertility. It's what's wrong with you?
Right.
What's wrong with you? It's no. you can ask him too. Like, he's part of the team here. Like, come on. Like,
Take two
you
to
know,
tango,
like, it
right?
takes two to, yeah, it's
to
like, it's
tango.
not just me. It's not just me. And I think as women, we tend to think it is just us.
Right, we think it's us.
We tend to think we're the problem. We're not the problem.
No.
Society has put that on us.
Yeah,
You know,
that
we-
burden.
Yeah. Yeah.
Oof.
Yeah, we know how to make it right, but we also
Yeah.
know how to interfere with some things.
That's right.
It makes me think about, while we're talking about motherhood and partnerships, it makes me think about this saying of a toxic mother is just as bad for a child as an absent father.
Yeah.
And the
Interesting,
reason why
wow.
I'm thinking about that is because when we're talking about relationships and we're talking about this collaborative effort when we're going to raise a child, those are characteristics and behaviors that we learn at home.
Right.
Yep.
And so
Yep.
I think from your display of everything you talked about and what you've shared here in this conversation, I think that you would provide a safe space for your patients to be able to say what's happening at home.
Yeah.
Because I'm thinking about the people who don't have that safety net. I'm thinking about the pregnant mom who, you know, I didn't even want this baby in the first place. Something happened, and this is how I got here. And then I'm thinking about the woman who has that diagnosis of breast cancer that does not have a community, right? And so what I love about what you brought to this conversation is you're allowing those viewers to see that there is help on the other side. Because I'm always thinking about who's not in the room.
Yep.
Who are we not mentioning that needs to be heard and seen and supported? You've touched a lot on those people. And so I want to thank you again for doing that. Because in any time you do a public speaking or something you're putting out to the community, there's some folks that you're going to get and they're going to be like, yep, they're talking to me. But then there's going to be someone sitting there who's like, they haven't said my thing yet.
Yeah.
And
That's
so
right.
I just, again, as someone who works closely with individuals who are impacted by intimate partner violence, I think it's crucial to share resources and ways of getting support that you need when we're talking about maternal health issues. Because I think maternal health issues often breeds those childhood adverse experiences. And so, again, thank you for being here and thank you for the work that you do.
Thank you. Thank you.
I think one of the themes from sitting here for this time with you guys is vulnerabilities.
That's why they love us.
Yeah,
That's what
it's
this is all about.
How can we as medical providers that really care about our patients' well-being encourage people to come with their vulnerabilities, and how do we sit and hold them with you, and not try to like react to it and fix you and it's just let's hold that together. So you don't have to be alone.
That's right.
And I think that may be reaching people who are listening today. Like, if you're worried about something and you just need a place to go to be heard, come and try to find somebody, or try to ask, or try to find somebody where you can be with. And I've had a lot. One of the things I cherish a lot are when my patients feel safe enough with me to trust me, and the number of times I've gotten interpersonal violent stories all the time, and it is so heartbreaking and prevalent, and people don't talk about it.
Right.
But I just, in my own practice, have heard a lot of those stories and hold them with people. It's about health and well-being.
It is.
Yeah.
They go together.
And just to say that, we've talked about preeclampsia and all these things that happen during pregnancy that put your life at risk, but the number one thing is actually intimate partner violence, and making sure I'm just so deeply appreciative of the work you do, because we know that this is a risk factor for when you're pregnant, that tends to increase in pregnancy and afterwards, that puts your life at risk. Wow. And that it's so important that if it's not that you feel safe with your doctor, but that you find someone that you feel safe with, that you have safety plans, et cetera, and that you acknowledge that as a vulnerability. And also the thing you said about, that maybe we're not touching your thing here today. Yeah, you're right. Like, there's so many things. But to elevate what Dr. Ko said about vulnerabilities, we want to hear about them. We don't have all the answers, and it's helpful to know that maybe you don't want the answers from us, but where we can help connect you to people, that's what we want to do.
That's right.
I know we're going to wrap, but before we wrap, for those who are watching who may be experiencing intimate partner violence, there is a resource at Boston Medical Center
Yes.
that you should reach out to. If you don't want to go directly to that resource, you have Dr. Ko and Dr. Joseph. Reach out to their office and say, I heard you talk about this thing.
Yes.
How can you help me get to that resource?
Yep.
So I just wanted to say that, and
Thank
I'll
you.
give it over to Cricket.
Thank you, ladies.
Thank you.
This was so good.
So good.
Yeah.
Because personally, I try to stay away from, like, not necessarily corporate, but the just the professional atmosphere, simply because I just know the toxicity that it could breed. But at the base of it, like, we're all humans,
Yes.
and we all have a story, and we all experience, and we all feel. And I was in there. I'm in this group. It's basically a group of all women, and it was just yesterday. I remember reading. This girl was like, "Is there anybody in here that I could? Is there a therapist that I could talk to in here? I don't really have the money to pay, but I just really need somebody to talk to and hold space, like you said, and hold space for me." And I was like, dang, like, I didn't have the emotional capacity to reach out. Normally I do, but I just like, girl, like, it just aches to just see somebody needing that and them not having it. And so I can't wait to let her know about this.
Is it the group that I know of?
Yes.
I think it's fair for us to name it, because a lot of the city, a lot of the women are in this group. The group that Cricket is talking about is on Facebook called Melanin Mass Moms. And you don't really, there are women who are not women of color on this group. But it's a group that is a safe space for women to talk about, whether you post with your name or anonymous, to talk about different things that we experience as women, whether it's motherhood or intimate partner violence, or looking for a resource for your child who has a autistic diagnosis, whatever it is.
Whatever it is.
Or you want to talk about, I have a teenage daughter. She's giving me an attitude.
Yep.
Who else got a teenage daughter? So I think it's fair to name the group, because again, that is another resource that is not the clinical aspect, but it is community.
Yes.
Right.
And also too, from both of us who are on this group, we see the changes that are happening in this group.
Yeah.
And that's literally what this space is about.
Yeah.
Again,
Right.
going back to the vision that Jasmine and I had with this project was, how can we ensure that we're not just giving people a number or an email?
Yes.
That's
or,
right. That's right.
How can we make sure that
Connecting
we're
them.
bringing them
That's
to
right.
connections that are meaningful, that are tangible, that can get them to the resources that they need? So
Right.
if you're watching and you're not a part of the Melanin Mass Moms group, I highly recommend that you consider. Again, you can be anonymous within the group, and I want to shout out the individuals who created it, to create that safe space for women, because we know that we as women, we got to stick together.
Yes.
That's right.
Yeah, I'm joining.
You ready to join?
I'm ready. Yes.
Nice.
So be prepared for them questions now.
That's right.
Join and be peeking. You got to be able to talk to the people.
All right, guys, this wraps up our episode of Women's Health with our team members at MA-CEAL and our beautiful doctors and partners from Boston Medical Center, Dr. Ko and Dr. Joseph. Thank you so much.
Thank you so much.
I want to shout out my coworker Jasmine for helping to put this vision into perspective, who's sitting behind the scenes and joining us and taking all the notes so we can continue these conversations. I also want to shout out the National Institute of Health. The MA-CEAL team is one of the sites. We're the only site in Massachusetts. We are funded by the National Institute of Health to do the work that we do. We also want to thank Boston Medical Center for housing us. And we hear it in community where folks say to us, "That's my hospital. That's the best hospital in the world." And so this is why. This is why. And so thank you for having us, Show and Tell Boston. We are extremely grateful. This is episode 5. We are getting ready for our final episode 6 for the year. So stay tuned, and we look forward to hearing more from the community.
Yeah.
Yes.
Thank you guys for asking these questions that matter.
Oh, right?
Thank
you. Thank you for showing up and being here.
Thank you.
All right, guys, it's a wrap. Peace out.
Bye.